All right, today we are doing a deep clinical dive into the 6 primary anxiety disorders. We're going to be working directly from the DSM-5TR, the official diagnostic guide. Our goal? To understand precisely what makes each one distinct, how you can tell them apart, and what the single unifying feature is at the core of them all. Let's get right into it. So think of this as a diagnostic funnel. We're going to start at the top with the one requirement that every single anxiety disorder has to meet. Then we'll start to differentiate, looking at phobias, then disorders of panic, then pervasive worry. After that, we hit the mandatory rule-out that you absolutely must do, and we'll wrap it all up with 6 diagnostic anchors, the key takeaways you need to have locked in. Okay, so before we can even think about which of the 6 anxiety disorders we might be looking at, there is one single core requirement that has to be met. This is the first filter. If the presentation doesn't pass this test, it's not an anxiety disorder, period. And here it is. The fear or the anxiety has to be excessive. It must be completely out of proportion to the actual real-world threat. It has to be persistent. This isn't a fleeting thing. And critically, it has to cause significant distress or impairment in someone's life. You have to remember those phrases: excessive, out of proportion, and persistent. They are the gateway.
So once that core requirement is met, our first job is to figure out the stimulus. What is triggering the fear? The first 2 disorders we'll look at are organized around a very focused, a very specific kind of trigger.
First up, we have specific phobia. And the name really says it all. The organizing principle here is a single identifiable thing. The fear is just completely and tightly bound to one specific object or situation. Think spiders, think heights, think flying on a plane.
Now, the cardinal criteria here are non-negotiable. The stimulus has to, almost always, provoke immediate fear. It's not a sometimes thing, it's practically a guarantee. And let's talk about the blood injection injury subtype for a second, because it is fascinatingly unique. With every other anxiety response, your heart rate goes up. But with this one, you can get a vasovagal response, a sudden drop in heart rate and blood pressure that leads to fainting. It is the only anxiety response that does this, making it a crucial diagnostic clue.
And this is absolutely critical: the duration. The fear, the anxiety, or the avoidance pattern has to be in place for at least 6 months. This is how we distinguish a true clinical phobia from a more temporary transient fear that might just go away on its own. We're looking for an entrenched, long-standing pattern.
Okay, now for our second type of focus fear, social anxiety disorder. Now, the fear here is a little more complex. It's not just about the situation, like being at a party. It's about the overwhelming, crippling fear of being judged negatively by other people in that situation.
So the absolute core fear is negative evaluation, being judged as weak or stupid or boring or anxious. The person is terrified they're going to act in a way that they believe will be humiliating. And just like with a specific phobia, these situations are either actively avoided or they are endured with just intense distress. And notice that performance-only specifier. We use that when the fear is really just limited to public speaking or performing in front of others.
And here we go again. Just like with specific phobia, the duration criterion is identical, at least 6 months. This consistency across both of these disorders really drives home how important that element of persistence is when we're making a diagnosis. It's a key theme you'll see again and again.
All right, we're making a major shift now. We're moving away from a fear of an external stimulus, like a spider or a social setting, to the fear of an internal one. These next 2 disorders, panic disorder and agoraphobia, are organized around what we call the fear of fear itself, the terrifying experience of a panic attack and the subsequent fear of being trapped by one.
The most important word on this slide, the absolute, non-negotiable critical key word, is unexpected. For a diagnosis of panic disorder, the panic attacks have to feel like they come completely out of the blue. There's no obvious trigger. If the attacks are always, say, cued by seeing a snake, then we're probably talking about a specific phobia, not panic disorder. Unexpected is the hallmark. And let's be clear, a panic attack is not just feeling nervous. It's a sudden, overwhelming tidal wave of intense fear that peaks within minutes, and it comes with a whole host of severe physical and cognitive symptoms. We're talking heart palpitations so strong you think you're having a heart attack, chest pain, a feeling of choking, and this terrifying existential fear that you're losing control or literally dying. It is a profound, full-body physiological event.
So diagnosing panic disorder is a clear two-part process. First, you need those recurrent, unexpected attacks. And second, for at least 1 month after, you need either persistent worry about having more attacks or a big, unhelpful change in behavior designed to avoid having them. So you see, the diagnosis isn't just about the attacks themselves. It's about the chronic fear of the attacks.
Now, this fear of panic attacks can lead us directly to our next disorder, agoraphobia. The core fear here is not actually of the situations themselves, but of being in a place where escape might be hard or where help might not be available if panic-like symptoms were to strike. At its very heart, it is a fear of being trapped.
And the criteria here are incredibly specific. The diagnosis requires marked fear or anxiety about 2 or more. Let me repeat that, 2 or more of these 5 situations: public transport, open spaces like parking lots, enclosed spaces like movie theaters, standing in line or in a crowd, or being outside the home by yourself. That 2 or more threshold is a mandatory diagnostic gate. This right here is a really key distinction to understand. You can absolutely have panic disorder without having agoraphobia, and you can have agoraphobia without ever having had a full-blown panic disorder. They are diagnosed independently. For instance, someone can have a crippling fear of having panic-like symptoms in a crowded place and avoid those places, even if they've never had a truly unexpected panic attack. They are separate conditions, even though they often go together.
Okay, another major shift. We're moving from focused fears of objects, situations, or panic itself, to a fear that is broad, pervasive, and what we call free-floating. And this brings us to generalized anxiety disorder, or GAD, which is really defined by its uncontrollable, all-encompassing nature. This quote from the diagnostic manual just perfectly captures the essence of GAD. The worry isn't about one thing, it's about multiple things. It jumps from finances to health to work to family. It's all over the place. But the absolute key, the defining feature, is that the person finds it incredibly difficult, if not impossible, to turn the worry off. And all of that constant mental worry is accompanied by very real, very physical symptoms. For a diagnosis, you need 3 or more of these 6 signs: feeling restless or keyed up, getting tired easily, having trouble concentrating, irritability, muscle tension, and sleep problems. And this entire picture, the worry and the physical symptoms, has to be going on for at least 6 months.
Now, before we land on a final diagnosis for any of these disorders, there is one last absolutely crucial step. We must rule out anxiety that is being caused directly by a substance or a medication. This is a mandatory, non-negotiable part of any differential diagnosis.
So the critical question here is about the timeline. Did the anxiety symptoms pop up during or soon after substance use or withdrawal? You know, common culprits can be caffeine intoxication, which can look exactly like a panic attack, or withdrawal from alcohol or benzodiazepines, which can create profound anxiety. You have to ask about it and you have to rule it out. First, always.
Okay, we've gone all the way through the diagnostic funnel. So to wrap things up, let's pull all of this together into 6 memorable diagnostic anchors. This is the clinical summary that you need to commit to memory.
And this is it. This is your final takeaway. For specific phobia, your anchor is a specific stimulus. For social anxiety, it's the fear of social scrutiny. For panic disorder, it's unexpected attacks plus that 1 month of worry. For agoraphobia, it's the fear of escape being difficult in 2 or more specific situations. For GAD, it's that uncontrollable worry across multiple areas, plus at least 3 physical symptoms. And for any anxiety presentation, our very first anchor is always the same: rule out substance or medication as the cause. So the question is never just, what's the diagnosis? It's, how have I systematically arrived at this conclusion, and what have I definitively ruled out to get here?